Good morning, everybody. So when it comes to hand injuries in children, you would see the commonest hand injury what we see in children is the door crush injury. So in fact, in our hospital, almost more than 100 cases of door crush injuries are treated every day. So that's why I thought I'd put few slides on door crush injuries, and which mainly will involve the fingertips, the nail bed, and also sometimes can result in tip amputations. The fractures and dislocations also are common in children, mainly because of various playing and sports activities and sometimes even fighting. So this is the commonest door crush injury you will get. So we can see over there that the initial presentation, it would look as if like the finger is totally amputated. But even if a few millimeters of connection is there, this finger would be viable unless we have sutured it inappropriately. Most of these fingertip injuries die just because of tight suturing. So if we don't put too many sutures, just loose suturing of the nail bed is done, then these fingers will mostly survive. So here a very important point is not to put too many sutures onto the pulp area. So thus that skin area is the one which is giving the blood circulation. So we should not put skin sutures there. We have to only repair the nail bed and not put much sutures onto the skin. So here we always say the money is for knowing not to put sutures. So just 2-3 sutures onto the nail bed will make it heal and children will get good results. The nail bed injuries, many times we neglect them, but over a period of time the nail bed would give such a severe deformities which are very, very difficult to treat. So we should treat them very seriously. Get a perfect apposition of the nail bed so that the nail comes out nicely and there is no deformity at all. One little different type of nail bed injury is the nail bed avulsion. So just to show in a picture, so nail bed comes off from its bed. So in these cases, if you don't relocate it nicely, the nail would not grow. And it will only grow into the skin, resulting in a pseudocyst formation there. So in such cases, we should make sure that we put this flipped out nail bed inside and put this kind of sutures to put the nail bed into place where it is very close to the germinal matrix, allowing a good nail to come out. Now what can be done for this type of injury? This is the extreme type of door crush injury where the fingertip has come off. So this is almost like a amputation what we commonly see in adults. But in children, just because it is a crush in a door, a very small part of tip is come out. So parents, since our center is very famous for replantation, they will all bring this part. But this part is not replantable because in such a distal area, the vessels will not be available. But in children, we can just put it back after defatting. This is called as a composite tissue grafting, and they do very well. So various literatures have shown that this procedure can be done for children, and the results are good if the procedure is done for children who are less than 5 years of old age. One very important point which most of the papers have found, that if it is done early, the results are better. So if the patient comes in night, we should not tell we will do in the morning, because if you do it early, chances of its take-up is much better. When the amputation is more proximal, it will not survive by just a composite grafting. It requires a microsurgical repair. Now coming to the fractures, the commonest fracture in children is a proximal phalanx fracture. Overall, 50% of the fractures are on the ulnar side and thumb fractures are a little bit less common. The same classification which all of you know. And when it comes to missing of the hand fracture, the commonest reason is that somebody has seen physis as a fracture or thought that it is a fracture when it is a normal physis. So that's why all of us should be familiar with the physeal arrangement in the hand. And one basic thing which we should remember is in the metacarpals, the physis are distal. In the phalanges, physis are at the proximal part at the base. And it is opposite for the thumb. So thumb physis for the metacarpal is at the base, and it is opposite of what is in there in the fingers. So when we see a fracture, there is a standard pattern of angulation what you will see at various fractures. All the metacarpal fractures would have a dorsal angulation because of the anatomy of the lumbrical muscle, the interossei muscles there. And all the phalangeal fractures will have a volar angulation. And the middle phalanx and distal phalanx fractures will depend on what site they are, and the FDS is the one which is going to determine the deformity which is happening. One thing which all of us must remember when we are treating fractures is this. So whenever a person is flexing the finger, all the fingers should point towards the scaphoid. So if they are not pointing, there is a rotational deformity, and this is the one which is the indication for all the surgical interventions for any fractures in the hand. If we have not intervened properly and the fracture malunites, the patients will have crossing over of the finger like that, and that will be a great functional disability. So a finger like this, which looks like it is okay, but when the patient will flex, it will just go crossover. And this type of fractures require a close reduction, and immediately the finger will fall in correct place. We can just strap them, even allow early mobilization, the result will be nice. Even in proximal phalanx fracture like this, where a lot of comminution is seen, a close reduction can give a very nice result like this. And this patient is the richest person in Coimbatore, so they were very surprised that how can you just put a slab, whether some plate is required. But in children, the results can be very nice just by close reduction itself. The main indications for surgical interventions are long oblique fractures, intra-articular fractures like this, which will require key wire fixation to get a good results. And one fracture which can be very problematic is a condyle fracture, which gets displaced and gets rotated. So that is one of the indications for open reduction. A few points about this fracture, which looks simple, but it can result in disasters, which is called as a Seymour fracture. It is a fracture of the base of the distal phalanx. It is basically an open injury. So if not treated properly, it can get infected. And also at this site, the nail bed goes inside, and which can result in a non-union and the nail bed deformity like that. Last case. Though many times we have been taught like physis can look like fracture, you can misdiagnose it, but we should not get carried away by that and miss some dislocation. So in this hand where the patient was presenting with index finger pain, it was looking like everything okay, but if we see little bit more carefully, we will find that there is an increase in gap in the MCP joint here, and in one of the spatial views, it is dislocated on the back side. So this is a Kaplan dislocation, which many times gets missed in children because of thought that it is just like a physis and a swelling there. It requires an open reduction almost always and will give good results. So just to put the famous statement of Swanson, where he emphasizes that most of the hand fractures should be treated conservatively and over treatment can be a kill for them, and it more so applies to children. And most of the literature has found that only 10 to 20% of pediatric hand fractures require surgical intervention. Thank you very much.